If you all have any preference for each day, I figure we could just do a show of hands.
Okay, guys. Thanks for your patience. Sorry. All right, a couple things. So you guys all know there's the extra credit assignment that's hanging out there in like the abyss, and you're not sure what to do with it or when to have it turned in. So if your exam's on a Monday the 24th, would, see, the 21st is that Friday. Would Thursday the 20th be a reasonable time to have it turned in by? Do what? Okay. So we'll do Thursday the 20th. I'll leave a box with Tracy on Tracy's desk, and you guys can just bring those up. I need it, turned in, actually a physical copy. Don't email it to me. I need you to actually print it off and bring it to me. Don't forget to put your name on it. I get that all the time because there's not a place on the asthma action plan for you to actually put your name, just the patient's name. So make sure you put your name on there, and I'll go through those and take a look at them and hopefully be able to, yes?
Is there a time you want us to have these into Tracy by on the 20th?
If they could be in by noon, that's great, but I'm not super picky about it. As long as I have them before the end of business on the 20th is fine. I can try, if you have them to me before that, I can try to review them and get them back to you before the exam to have them to study with, but that's kind of a crapshoot. I don't know how that'll work out, so time-wise. But if you have any questions specifically about asthma action plans and I don't get it back to you before, email me, let me know. I'll be happy to talk you through it, not the assignment specifically, but through asthma action plans. Let's see, other things. Let's see. Let's see. There is actually an Ellipta inhaler. I was going back through some of my stuff today, getting ready for class, and I realized, I told you guys there are 3 Elliptas that are going to be on the market by January. There's the Anoro, the Incruse, and the Brio Ellipta. There's actually a 4th one that I had forgotten about, and it's called Arnuity. Arnuity, and that's fluticasone by itself in the inhaler, so it's indicated for asthma specifically. And then, we talked about with asthma too that there is the controversy over keeping a long-acting beta versus taking it away for people who, because steroids are your backbone, and then there's always controversy around the long-acting betas. There was actually a study, and I was looking back at Thorax, the journal called Thorax that came out just a couple of months ago, maybe like September, something like that, and it compared Brio Ellipta, which is the fluticasone and vilantriol, to fluticasone alone for patients who were already on medium dose steroids and still were having exacerbations with their asthma. And they actually proved a number needed to treat of like 33 to prevent a severe exacerbation at 1 year. So using the long-acting beta in addition to the steroids. So just some more information about steroids and asthma specifically. I wanted to make sure I didn't forget. Okay, so now my favorite topic, COPD. Oh, I love it so. Okay, so the GOLD guidelines, which are the guidelines that are for COPD, they're updated every January, but the updates are usually pretty mild. So there's not a lot that changes year to year, but it's still probably worth taking a look. Kind of like, how the diabetes guidelines update every January. Sorry. Okay. Your textbook is not up to date, so don't read any therapy stuff out of DePiro. Pay attention to the GOLD guidelines and pay attention to my notes. Okay, so I broke this up into 4 different parts, lecture-wise, so that we would just kind of have everything like step-wise. So we're going to talk a little bit about how we got to where we are with COPD. So it's going to be a little Dr. Crossy here for just a minute, but I'll try to keep it together. So pathophysiology of COPD. These are some of the things we may have talked about last week in patient assessment, or you guys might already know about COPD. So remember, there are 2 things that make up the umbrella of COPD, and that's chronic bronchitis and emphysema. Okay, we used to say, oh, this person has emphysema, but this person has COPD. Well, actually, they're both both are under the umbrella of COPD. Okay, so you have a chronic inflammation all the time that's happening, and because of that inflammation, you kind of get swelling and a blockage of the large airways. So they get swollen, they're enlarged because they're inflamed, and then the radius or the diameter of the opening in your airway is smaller, and as you decrease the radius, you increase the resistance, right? So that's all physics. So as you try to breathe out, you meet resistance with your air. So these patients, we talked about last week that typically your inspiratory to expiratory ratio is like 3 to 1, 3 seconds in, 1 second out. People with COPD will have a much longer expiratory phase because they have a really hard time getting rid of air, okay? Because they have a hard time getting rid of air, they hyperinflate. So over time, they'll get air trapped in their lungs, and it'll push their diaphragm down, and their lungs will become real big. They'll get barrel-chested. You may have seen some barrel-chested patients. And if you look around anywhere, I mean, you can't throw a rock in East Tennessee and not see somebody with COPD. So just be, kind of be aware, be looking for it. They have very typical features. Sometimes they'll have the overexposed neck muscles. They may be very skinny, or they could be larger and have that barrel chest. Mucus hypersecretion, because of the inflammation, the goblet cells in the lungs actually hypertrophy and proliferate more, and so that's what makes the mucus in your lungs, and so they get this real thick, nasty mucus they can't get rid of. And then the worst thing about COPD, other than the fact that we can't fix it, is exacerbation. So every time a patient has an exacerbation with COPD, their lungs never return back to the baseline level it was before they had that exacerbation. It's a really important point. This is just that example of hyperinflation. So on this side, on the A, you have kind of a normal lung, okay? And then you see a hyperinflated lung on the right side. Yeah, that's your right. See how long those lungs are? Can't even fit the whole lung in the window of the x-ray machine, so that's pretty big, okay? That's not good. You would think, oh, you have more lung space, good for you. That's not the case here. So we breathe like people in this room, okay? We breathe because we sense a rise in our CO2, okay? So our brainstem notices our CO2 level starts to rise, and then it causes us to take a breath. That's why you can't hold your breath. You physically, like your body won't let you hold your breath. Like you can try, you can hold it, but eventually the need to breathe is going to overcome anything else. So that's because we have an elevation in our blood CO2 levels. That's not the case for people with COPD. They have a kind of a flip in the mechanism for their drive to breathe, okay? Because they'll chronically retain CO2 because they can't exchange gas very well. So their CO2 level may be, a normal CO2 is in the neighborhood of 35 to 45. That's kind of a normal. Somebody with COPD may chronically live with a CO2 of 60 all the time, and they're walking around normal. You'll hear some people call them anaerobes. We talked about that a little bit in patient assessment because they literally walk around at levels that the rest of us would die at, okay? They need like no oxygen to breathe. So because of this, their need to breathe switches over to a decrease in oxygen saturation. So as their oxygen saturation decreases, that's their drive to breathe, okay? So that's important because if you over-oxygenate a patient with COPD, you can actually kill them because you will drive their oxygen up so high that you'll depress their breathing. Does that make sense? That's going to come in really important. I know in the hospital all the time, the residents will put somebody on with COPD. They'll come in and they're hypercapnic, so their CO2 is really high. And they'll put them on a non-rebreather mask, which is a mask that doesn't allow you to rebreathe the same air that you just blew out, so it's almost all oxygen that you're breathing in, or even BiPAP to help them blow off CO2, okay? And they'll drive their oxygen up to 100%, and they'll come into the room with the attending, and they're like, you're going to be so proud of me. They got their oxygen level up to 100%, and the attending usually gives them a little smack on the face and tells them, no, you're actually doing that wrong. So that's just kind of one of those things. It's an interesting difference between how normal people breathe and how people with COPD breathe, okay? So oxygen at the end of COPD is one of the few things that's been shown to help, like, extend the patient's life, okay, oxygen therapy. But it's also very dangerous. And to us, if we breathe oxygen all day long, it'd be totally fine, right? But for patients with COPD, it's kind of like, that's why we don't always start that early, is because it can be dangerous for patients if their level gets too high. So we, just to kind of give you an idea and kind of finish that thought, so we walk around with an O2 sat somewhere between like 97 and 100%. This marker sucks. Well, that one does too. I'm going to just throw them away. How about that? There we go. 100%, okay? A goal for a COPD patient might be somewhere between 92 and 94%. That would be like their goal O2 sat when they came into the hospital. That one works too. Perfect. Okay. So this is just a little graphic to kind of show how COPD is a vicious cycle. So basically you have airflow obstruction, leads to that hyperinflation and air trapping, and then you have limited activities and you have shortness of breath, okay? And both of those things lead to other problems that then kind of are like feedback loops that then make the air trapping worse. And at the end of the day, these people have a very poor quality of life, which I think it probably goes without saying, but you know, just kind of thinking about all the things that go into it. Anxiety is a huge problem for these patients because if you can't breathe, if you feel like you're air hungry, you're very anxious, right? Like it's like, I got to breathe right now, and you start to get nervous. So these patients are very anxious. I actually knew a lady that had COPD, and she passed away from COPD probably maybe 4 years ago or so. And she was so anxious that she wouldn't ride in the car with anyone because she was afraid that she couldn't get to like her cigarettes or her oxygen during that time. She caught her face on fire like 3 times because she would wear oxygen and smoke. So she had like no eyebrows at the end of her life because she had burned them off. But it was really, really sad because, I mean, like she was literally trapped in her own house because to ride to town was like, she had so much anxiety around that she couldn't hardly do it without like 4 Xanax. So kind of the difference is she looked, this lady I'm speaking of, looked more like this patient. Very, very skinny, cachectic with those large neck muscles. Sat like this a lot because it's easier to breathe if you lean forward. That's more typical. We call those pink puffers. Okay? And they'll kind of breathe real fast and shallow like that. And those patients typically have more emphysema as the main component of their disease. Now, they may also have chronic bronchitis, but emphysema tends to make these skinny little patients that look like a pink puffer. So their lips are real pink. Everything might look real pink, but they're having a hard time breathing. In contrast, the guy on the other side there, he's what they call a blue bloater. So he has more chronic bronchitis. Is a larger component of his disease. Typically, those patients will have like blue-gray coloring around their lips or their fingernails, okay? And they are going to be the ones that have that really long expiratory phase. So they're going to go, and it's going to take them forever to get rid of all the air that they can actually move out of their lungs, okay? That's a good, hopefully, review about pathophysiology. If you guys have any other questions, let me know. But now we're going to talk about management. So there's lots of things. We want to diagnose it early because the earlier we catch it and intervene, the more likely we are to have a better outcome. That's true in everything. Reduce risk factors. What's the #1 risk factor for COPD? Absolutely, smoking. Smoking, actually, cessation is the only therapy option that has been shown to improve mortality. Okay? So if a patient will stop smoking with COPD, it actually increases their life. With things like, you know, we've looked at all the medications we've ever looked at. We've never had a medication that's proven to improve mortality, with the exception of like the flu vaccine. So giving a patient a flu vaccine if they have COPD has mortality benefits. But other than that, those are our only things. So stopping smoking. Symptoms, big problem here because this is going to be a symptom-driven treatment process. Patients, depending on what their symptoms are, it's going to pretty much tell us what we use to treat those patients and how aggressive we are. Prevent exacerbations, and then monitor the progression of disease over time. Okay, so now a little history lesson. So prior to 2010, the GOLD guidelines, when we looked at patients and staged patients with COPD, it was only staged based off of their pulmonary function testing. We didn't care what their symptoms were. We didn't care how many exacerbations they were having. It was like you were basically a number, okay? So the problem with this is all based on cohorts. And you might have a patient who has really poor lung function, like they're in a severe or very severe category, but they don't have a lot of symptoms that patients that have maybe even better lung function might experience. So it wasn't really individualized to the patient. We were just treating people in these huge groups. So things to remember here, this still is true. To be diagnosed with COPD, you have to have an FEV1 to FVC ratio of less than 70%. That's diagnostic. Okay? Then we break up our COPD groups, and these categories still hold true as well. Okay? So then we break up our groups based on different cohorts of FEV1 impairment. Okay, so as their FEV1 starts to decrease, that's how much they can blow off in 1 second. That tells us kind of how severe their airflow limitation is. That's a risk factor. Okay? Based on that, like I said, was pretty much what we did to treat patients. We said, okay, well, if you're in the mild category, I need to reduce your risk factors with flu vaccines and give you a short-acting beta agonist. And that was all the thought that went into treating these patients. There was nothing about the individual patient themselves, okay? So this is all old stuff. But it's really important because even just probably 3 months ago, I went to one of the noon conferences that the family medicine team was giving, and one of the attendings was speaking on COPD and was, really in there and just giving it all he had, and he was actually using the old guidelines. So lots of people aren't even aware that they've changed like how you stage patients with COPD, so you might be the only person that knows that. Hopefully not anymore, but I still run into people who don't realize that it's changed. So like I said, these were some of the criticisms that came along with these older guidelines. There was no individualizations. There was no symptom consideration in your treatment. And we really didn't have any emphasis on goals. We didn't really care about goals. We were just like, okay, what's going to get you through the day today? Not necessarily what's going to help you 5 years from now. So in 2011, everything got revised, okay? And this was the actual goal that they said, this is the reason why we're doing this, okay? To individualize therapy and focus on symptoms. So there are 4 things that go into this new assessment, okay? And you guys I'll give you this box on the exam, and you can write your notes in it if you want to. However, that's terrible. Okay. So we're going to fill this thing in. Okay? Talk about it. Okay, so symptoms, obstruction, exacerbations, and comorbidities. Okay? So the first thing is to assess symptoms. I'm not going to try to pull this up because I think it might freeze up the PowerPoint with all the craziness with this computer, but we'll pull it up tomorrow and I'll show you. There's a test online called the COPD assessment test. It's oftentimes called the CAT score or the CAT test. It's it's online. It comes in like 5,000 different languages. A patient can take it at home, and it's Likert scale questions. So it'll be like, my COPD keeps me awake at night, never or every night. And they'll kind of pick along that scale, kind of like a pain score, how much that thing impacts their quality of life for their symptoms. And at the end, it gives them a score that kind of tells them how severe the symptoms of COPD are affecting their quality of life. It's super easy. It's free. It takes probably 5 minutes at most to get. Okay? And the best part about that one is it's all symptoms. It's sleepiness, it's breathlessness, it's inability to leave the house because you're impaired kind of thing. The Modified British Medical Research Council questionnaire, or the MMRC, is this little guy that's in the white here. And it's basically you just check the box that best describes you, okay? But this only looks at breathlessness. So how breathless is the patient doing these different levels of activity? They would pick the one that was best for them, but it doesn't ask them anything about any other symptoms, okay? So our symptoms are going to go here at the bottom. So this is our symptoms. I'm sorry, I know this is symptoms. I know this is lower than some of you can see, but it's actually on the slide too, so don't fret. Okay, airflow limitation. So like I said, spirometry has to be used to diagnose COPD. Airflow limitation is going to go over here as a risk category. And the easiest way to remember this is anything above this line is less than 50%. Anything below this line is greater than 50%. Okay, so as your airflow limitation gets worse, you move up this side of the category, or this side of the box. Okay, exacerbations are probably the biggest risk factor for a patient with COPD for worsening quality of life or worsening airflow. Okay, so this little box actually comes directly from the GOLD guidelines. This is conglomerate information from 3 of the biggest COPD trials that were ever done: the TORCH trial, I think INSPIRE, and ISOLID maybe. I have to go back and double check that, but it's all in there. And it basically shows you, so these mild, moderate, severe, and very severe, remember these are those categories of FEV1. Okay, so as you move down, so these GOLD, very severe, are less than 30% FEV1, 30 to 50 in the severe group, and then so on and so forth. And you can see there, as your airflow limitation worsens, you have a higher risk of exacerbations each year, a higher risk of hospitalizations, and look at your mortality, how it changes, your 3-year mortality. So so preventing exacerbations has become like the new focus for COPD. Okay. So what is an exacerbation? It's anything that changes your therapy. Okay. So anything that changes your day-to-day use of your medication or your therapy is by definition an exacerbation. So why is that important that we make that definition is a lot of people at home may not even tell you they're having exacerbations. They may go through a couple of days where they need their albuterol more frequently, 4 or 5 times a day compared to once or twice a day. By definition, that's an exacerbation. So you need to ask patients about those kinds of use of their inhalers, because they're probably just going to tell you, oh yeah, I had to go to the doctor last week or 2 months ago because I had an exacerbation, and not tell you about those things that might happen at home that don't bring them in for care. So this is our little box again. So like I said, on this side we have our risk. That is our level of airflow limitation. On this side we have our risk and exacerbations. Okay. Okay. So if a patient's had, and this is in the last year, pervious, that's not the right word. Okay, this is how this is measured. So if a patient's had 0 or 1 exacerbation in the previous year, they're going to fall in these lower risk categories, just like the patients who have better FEV1. And if they've had 2 or greater, they're going to fall in the more high risk categories because they're having more exacerbations. Now, it's not on this slide, but because I'd already posted these when I looked at the update, but there's actually a new classification here. So if a patient has 1 admission for COPD, that also puts them in the higher risk category. Okay, so if they've had 1 exacerbation in the past year, but it required them to be hospitalized, that also makes them at higher risk. So they would also fall in those higher categories as well. And then the bottom, you have your symptoms, okay? So low-risk symptoms or low breathlessness would be those MMRCs of 0 to 1. Okay? Here, it's greater than or equal to 2. And then your CAT score, 0 to 10, right? Or actually 0 to 9. Okay? And then greater than or equal to 10 are high-risk symptom patients. So on the test, I'll give you a second sheet, and what you'll have is you'll have this whole thing, okay, with your symptoms, your scores, how everything kind of falls out. I won't have this less than 50 or greater than 50 thing, but I'll have the 1, 2, 3, 4, and then I suggest that you use that like to write your notes on. So historically, what students have done is after we start talking about the therapy in each of these boxes, the first thing they do on the exam when I hand them that sheet is they write in the therapy choices for each of those patients. Because if you can stage a patient with COPD, it's really easy to pick out what therapy is right for that patient. Okay? So use that to your benefit. It's not important. Okay, so now having all this, let's practice and classify some of these patients. So patient 1, a 75-year-old male, smokes 2 packs a day for 50 years, has had 3 exacerbations in 6 months. His FEV1, so that would put him up here, right? So he's now up here. His FEV1 is 60%, which would actually put him down here because it's greater than 50, right? And then he wears oxygen around the clock at 3 liters. So where would you put that patient? I heard a C whispered from somewhere. Anybody want to argue for a D? What's the difference in C and D? Symptoms, right? Yeah. So what about this patient makes you think he has more symptoms than the average bear? He wears oxygen around the clock, right? So this patient would probably get classified as a category D, okay? Because exacerbations put them in a higher risk category, and because we have that, we don't have these scores to tell us that, but that's common sense. If a patient requires oxygen around the clock, they're clearly having significant symptoms that impact their quality of life. Yes? Okay. Questions about that one? So the take-home point also here is you have FEV1 that puts you in the low risk categories, but then exacerbations that put you in the high risk categories. Always default to the highest risk. Okay? Just like with asthma we talked about, you would always default to the highest risk or the best treatment for that patient, especially initially. In COPD, you're always going to default to the one that gives you the highest risk classification for that patient. Patient number 2, 45-year-old female, 30-pack-year history, quit 2 years ago, a CAT score of 13, but she's never had spirometry testing. So where does this patient fall? Okay, I heard some B's, right? Yeah, technically it looks like she might be in a B. The catcher here is she's never had spirometry, and you can't say a patient's had COPD if they've not had spirometry. That's diagnostic. But you're right. I mean, if we were just going to use this information today to start therapy, she would probably fall in the B category because of symptoms, right? Okay. Number 3, a 64-year-old female, 1 exacerbation in the prior year, an FEV1 of 40%, and a CAT score of 25. Sorry? D, right? Yeah, so she's really high risk. That whole 1 exacerbation in the previous year, that's probably the patient you want to ask, okay, tell me how you're using your inhaler at home. Because she's probably having more symptoms at home that qualifies an exacerbation, but she's not telling anybody. Patient 4, you see MMRC of 1, a CAT score of 20, 1 exacerbation, and FEV1 of 60%. What do you guys think? Probably a B, right? So here's an example of how the CAT score and the MMRC differ. because you only get breathlessness with the MMRC. So it actually scores this patient as having fewer symptoms, okay? But then when you start asking the patient about things like ability to walk around the house and do household chores, ability to leave the house, ability to sleep through the night, mucus production, things like that, this patient's actually having more of those symptoms and maybe not as much breathlessness, but some of the other symptoms are more significant. Yes?
Trying to look up the CAT score online.
Uh-huh.
It says that U.S. residents can't take it. Do you know anything about that or why?
No, I'll look at the website. I'll look at it when we take a break and look, because you should be able to take it, no problem. It might be to do with the language setting that's in there, because sometimes it'll default to like a foreign language and then you have to reset it. So I'll look at it and see what's going on. But yeah, you should be able to access that, no problem. We do it all the time in clinic with patients. Any questions? Yes.
So is there like a certain CAT score where we like move them over to the next, like from C to a D, based on like a certain?
Yeah, it would be this one. So from 0 to 9 would be a C category, and then from less or greater than 10 would be D.
Okay.
So higher CAT score would be. So basically what this means is patients in category A have the least amount of risk and the fewest symptoms. Okay? Because you see where they fall on all the axes. They're having few exacerbations, their airflow limitations not real significant yet, and they're having few symptoms. So they are the least significantly affected patients. Category D patients are the most severely ill patients. So they have the highest risk, the biggest airflow limitation, and the biggest level of symptoms. And that's kind of how you move along the spectrum. So just like in the alphabet, A, B, C, and D, that's your order of severity. Good questions. Thanks. Anything else? All right. Let's see if I can now open up the second one. Fingers crossed. Oh, perfect. Okay. All right. So let's talk about some therapy options. We're going to kind of breeze through this one because you guys have already had asthma, but don't let me go past something you don't understand. Okay? Or if you need clarification or you want to talk about it further. I put up kind of the actual chapter is chapter 3 of the COPD Gold Guidelines, and the guidelines are really easy to read. It's big print, it's little bitty paragraphs, and each paragraph, when it tells you something, it'll actually reference that back to the study that told us that. So it's a great place to go to find primary literature for COPD because it's all in there. Okay. Let's see. We need to be able to talk about non-farm options, farm options, and then being able to put that to patients, which is, at this point, pretty much what we do in every class, right? Okay. So like we said before, there's no pharmacotherapy that's been shown to modify the long-term decline in lung function. Here's another one that people often argue about, okay, is this second bullet point. The method of drug inhalation has not been shown to have a significant difference in benefit. Okay, so patients, so tell me, how do you counsel someone to breathe out of a dry powder inhaler? Is it quick or is it slow? It's quick. It's a quick deep breath, right? Versus a slow deep breath that you would have with like a metered dose inhaler or a Respimat, right? So a lot of people argue that COPD patients can't use dry powder inhalers very well because they don't have the capacity or the inspiratory drive to do that. They get all that air stuck in their lungs, and they can't take a deep breath. If they could, they wouldn't have COPD, right? So a lot of people will argue that dry powder inhalers are actually terrible for patients with COPD, especially as they progress into those later stages. Now, why is that a problem? Spiriva is a dry powder inhaler, right? And that's one of the therapies we use for COPD patients. Advair is a dry powder inhaler. That's a very commonly dispensed inhaler for COPD patients. So there's argument there, but there's no evidence to tell us that any one device is superior or inferior to another device, as long as they're given at equal potent doses. Okay. The other thing here is always remember that pretty much, as far as we know right now, therapy is always additive. So with COPD, typically when a patient starts on a long-acting agent, they're never going to come off of that. And when you add Spiriva to Advair, the patient's always going to have both of those inhalers. So they'll just continue to add therapies on as their disease progresses. Questions? Okay. Non-pharm therapy, easy cheesy. Smoking cessation, we talked about. Obviously the most important thing you can do for a patient with COPD. Reducing indoor air pollution. We don't think about that a lot in the United States, but this is actually low quality air, like from like wood burning fireplaces in poorly insulated or ventilated homes in like third world countries. That's the main reason they have COPD. So if you ever did like mission work or any kind of like foreign pharmacy in a underdeveloped country, that's just something to think about. Is it's probably not smoking that causes them to have COPD. Environmental triggers. So lots of patients, you know, if they are exposed through like their workplace. So my grandmother's best friend lived in Michigan for the majority of her working life and worked in a car factory, because what else do you do in Michigan except work in car factories, right? No offense if you're from Michigan. But, you know, I mean, that's a major industry there. And she's never smoked a day in her life, never picked up a cigarette, but she has really bad COPD because of the fumes that she inhaled in the car factory and the poor quality of air and the environmental stuff she was breathing in. So that can also be a problem for some patients. Pulmonary rehab, this just helps keep patients active. So like they'll have these exercise programs they go to, or they'll have breathing exercises that the pulmonary rehabilitation can teach them about how to make themselves less air hungry. So, you know, like pursed lip breathing. So oftentimes for patients who are having a lot of shortness of breath and they're kind of panicking through that expiratory phase, they recommend that you do pursed lip breathing. So it's like kind of like we talked about the duck face, like, so they'll kind of purse their lips together and breathe really slowly through their lips, and that can help sometimes kind of calm them down. And then this last one is kind of controversial, but I just added it as kind of a talking point. Nutrition counseling. So there's some people who think that we should limit carbohydrate intake in patients with COPD, because what do carbs break down to? CO2, right? So they're already chronically retaining CO2, and so there's some people who prescribe to limiting carbs in these patients, but maximizing protein. Because over time, these patients are going to break down their proteins, they're going to become malnourished because they spend so much extra energy breathing. So they burn a lot of calories just staying alive, a lot more than any of us, because they're trying so hard to breathe. So they have to have increased protein, and the argument about if they should or shouldn't have a normal amount of carbs is debatable. Vaccines, influenza, so proven mortality benefit we talked about. Pneumococcal vaccines have shown morbidity benefit in decreasing admissions or incidence of community-acquired pneumonia in patients with COPD, so you have less pneumonia if they have a pneumococcal vaccine, but there's never been any mortality data that's been shown with that, just the influenza. But still, we recommend it for patients because it has that decrease in pneumonia. Exercise training, and then control of comorbidities. So patients with COPD oftentimes suffer from really severe depression or anxiety, and so you've got to treat those things. They also oftentimes will have concomitant heart disease because of the cardiorespiratory system. It's all intertwined. And so they may also have like heart attacks more often, or heart failure even. They sometimes can have pulmonary hypertension after long-standing COPD, so you've got to treat that as well. So don't forget about those, and don't forget to ask about those, because they're real important in quality of life. Okay, now classes. So pretty much it's broken down into bronchodilators, steroids, and our PDE4 inhibitor, roflumilast, or Daliresp. Okay? These are our only classes that we really treat COPD with. Okay? And primarily, like we talked about, the difference between asthma and COPD, here, these are your backbones. You have to have a bronchodilator on board. all the time. We add steroids to patients as they need it, but that's not a primary. You would never have a patient with COPD. Well, you should never have a patient with COPD just on an inhaled steroid and a short-acting beta agonist. They need that bronchodilation. Okay? There's actually a new drug that doesn't even have a name yet. It is, I'll make sure I got all the letters right, RPL 554. And it's like Verona Pharma is the name of the company that's marketing this right now. And it's like a novel therapy. It's going to be intranasal, so it's different than some of the other medicines we use for COPD. But it inhibits PDE4 and PD3. So both of those are pathways that are negative or pathophysiologic in COPD, PDE4 or PDE3. And so this is like a new novel therapy, which is the first one we've had in a really long time. Okay, so let's talk about each of these agents, some of their side effects. Okay, so beta-2 agonists, how do they work? They increase levels of cyclic AMP. If you have increased cyclic AMP, you have bronchodilation. End of the story, right? What makes a beta agonist go from short-acting to long-acting is lipophilicity. Okay, so the more lipophilic an agent is, it gets stuck. Remember, like when you were talking about cell membranes, and there were like those lipid rafts that floated around, kind of in the membrane. So the long-acting beta agonists get stuck in those lipid rafts and slowly release over the course of the day, and that's what makes them long-acting as opposed to a short-acting albuterol. Okay. It also has to do with the side chain and how long the side chain is, and a bunch of stuff that I'm sure Dr. Brown can teach you about way better than I can. They also help you increase your clearance of mucus, so like those ciliaries that are kind of like inside the lungs, helps move those faster to clear out debris and mucus. Here's an important point. Bronchodilator effects have not shown tachyphylaxis with long-term use. Okay, so there's a lot of argument about whether or not using long-acting beta agonists over a long period of time actually decreases how effective they are. So it takes more of the same dose to get the same effect, like with nitroglycerin. Okay, so that's kind of a controversial point. Historically, we've said no, there's no tachyphylaxis. You can just use them as long as you want to, and it's totally fine. But there's actually some new evidence now that says that there may actually be some tachyphylaxis, and that over time the response to the same dose is diminished. Obviously, you guys probably all hear about tachycardia or tremor as side effects of these all the time. People will come in and say, oh, I just can't take that albuterol. You know, it makes me crazy. I'm like, you're probably crazy before. This is just a picture of, you know, the mechanism in case anybody in here just loves that stuff. I'm just going to move on through it. So in COPD, what does this look like using beta agonists? We use the short-acting agents for rescue therapy. Regular use has been shown to decrease shortness of breath and improve lung function, and that's measured through FEV1. Okay, so that's the improvement they're talking about. Long-acting agents are better than short-acting agents. So if you have a patient that's requiring their short-acting beta agonist throughout the day, it's time to switch them to a long-acting agent. Okay, because they're more beneficial for like 24-hour coverage. And then there's some reviews or studies that have shown that long-acting beta agonists can reduce your rate of exacerbation by up to 20%. So that's significant. That's 1 in 5. Okay? So they're a go-to first-line agent for COPD. Okay? Anticholinergics are our second go-to agent that we'll oftentimes initiate in patients with COPD. And this is about all the pathophysiology behind that. So patients that have COPD have an increase in cholinergic tone in their lungs, okay? And what happens with that is you have an increased bronchial tone, so they're more reactive and they're more constricted, okay? And they also have mucus hypersecretion related to that. Because remember, what happens if you give somebody an anticholinergic? What's on the main side effects? Dries everything up, right? So cholinergic activity leads to like wetness, mucus, all those things, okay? So important take-home point about COPD specifically, The M1 and the M3 receptors are what help us, when we block those, then we actually get bronchodilation, okay? Because if they're activated by acetylcholine, then you get bronchoconstriction. The M2 receptor is a feedback mechanism. So when acetylcholine binds there, it actually gives you a feedback to inhibit the release of more acetylcholine. So that's like your negative feedback, okay? So knowing that, which of these receptors do you want to inhibit in COPD? Like if you could pick one of those to inhibit, which one would it be? Or two? Or do you want to do it all? 1 and 3, right? Yeah, because if you inhibit 1 and 3 and you block the acetylcholine binding, you're going to have bronchodilation, okay? Actually, if you block M2, if you block that receptor and you shut down that negative feedback loop, you can actually get bronchoconstriction. So blocking M2 long term can actually lead to like the opposite of what you're trying to do. And that's going to be important in just a second when we talk about our different agents. A picture. Okay. Ipratropium is non-selective. So that's our short-acting Atrovent, right? It's a non-selective and it binds to all 3 receptor subtypes, 1, 2, and 3. Okay? Ipratropium typically lasts in a patient anywhere from 6 to 8 hours. So that's about how frequently they're going to need that medication. So how often does someone usually get a prescription for Combivent, which has ipratropium and albuterol? What's the SIG normally say on that? About every 6 hours, right? Yeah, that's because of the ipratropium component, okay? Tiotropium actually also binds to all 3 subtypes, but then quickly it pops back off of M2, okay? So it lets go of M2 really fast and just binds M3, and it binds for longer than 24 hours. Actually, it binds for about 27 hours, and that's about how long you get effect. So really, really long onset of action. That's why it can take a little while to get up to your full effect, okay? So typically if somebody starts on Spiriva, you should tell them you're not going to see the full effects of this medication for probably a week to 2 weeks because of that long half-life. Okay. Iclibnium or umeclidnium are the 2 new ones. I don't have that one on the slide here. They bind only to M3, so they're kind of like tiotropium as well, but they don't even have that real, quick onto the M2 receptor. They only bind M3, so that's what makes them really cool and novel, and they get to come out in fun inhalers. So, having said that, please, if you don't learn anything else from me, learn this point, okay? It is perfectly fine to have a patient on a long-acting beta agonist and albuterol for rescue therapy. That's fine. Because if you add a long-acting, or if you add a short-acting beta to a long-acting beta, you still get benefit. Okay? So a patient could be taking their Stalmeterol, oh, I'm suddenly short of breath, let me take my albuterol, and they will acutely feel relief. Okay? That is not true for anticholinergics. So if you have a patient on tiotropium, it is inappropriate to also have ipratropium in their regimen. And that's all because of those receptors, the M1, 2, and 3, and what they do, and how long tiotropium binds to M3. That's true for all the anticholinergics that we're talking about in this class for lungs, okay? That what part? That whole thing? Yeah, so ipratropium, so I'll start from the beginning because I don't know what I said. I never know what I say. So ipratropium, short-acting, binds to 1, 2, and 3, right? Tiotropium, long-acting, binds to M3 primarily, and that's what we're looking for in COPD, is binding to the M3 receptor. So to add both of those together, so if somebody was on tiotropium for maintenance therapy and they were looking for rescue therapy and you gave them Atrovent, which is ipratropium, or Combivent, which has ipratropium in it, that's inappropriate because that's a duplication of therapy. And actually the ipratropium, because it has that M2 selectivity, can cause them to bronchoconstrict acutely around the time they take it if they're already taking tiotropium. So take-home message is, don't stack your anticholinergics. It's okay to do that with beta agonists, not okay with your anticholinergics. Is that good? Yes. Okay, perfect. No problem. Adverse effects, this is all the anticholinergic stuff, dry mouth, metallic taste. That's another reason why, even though this is not a steroid, you might counsel patients to rinse their mouth after they take these medications. Urinary retention, we worry about lots of times in patients, especially men who have large prostates. So older men with BPH sometimes will experience urinary retention around the time that they start taking these medications. Cardiovascular events, I kind of put a question mark there. So the reason it took the Respimat inhaler with tiotropium so long to come to market in the United States was there were some meta-analyses that looked at cardiovascular events in patients who took tiotropium through the Respimat device and found increased risk. And so the FDA initially said, no, can't do it. We're only going to have the HandiHaler device in the United States. And recently they did this big study and compared the two. It was like 17,000 patients and found it was non-inferior. So it's okay. It's about the same amount of risk. But that's kind of an ongoing debate all the time about anticholinergics in general causing more cardiovascular events. And this is a good one too. Don't forget, face magnets can cause, if you have glaucoma, it can actually precipitate it because it can kind of blow up into the eye itself and work on the cholinergic receptors in the eye and can cause patients with glaucoma to have problems. Okay, so here's how they benefit us in COPD. You guys can read that. No need for me to bore you with that. But basically, tiotropium has been shown to be superior in general to ipratropium, okay? And overall, pretty much the same benefits we saw with beta agonist. Increased quality of life, better symptom control, but no change in mortality. Methylxanthines, historically theophylline, okay? We used to have aminophylline, which was IV. But we can't even get that anymore, I don't think. Remember, narrow therapeutic index on theophylline. So we've got to be real careful about how you change doses because you can become toxic really fast. Hopefully, you'll never have to worry about this drug because it really belongs in a museum. We shouldn't be using it. But you'll have like older patients that are on it, people who've had lung disease for a long time. Let's see, I put some of the mechanisms down there. Kind of a fun fact about theophylline. Remember, it's got tons of drug interactions. One of the biggest ones that's most commonly seen for patients with COPD is Cipro. So Cipro specifically, because of its metabolism, it's different than Levaquin, different than moxifloxacin, but there's actually a recommendation if you look in the package insert, if your patient starts on Cipro, you're supposed to like cut the dose of theophylline in half or something like that because it can acutely elevate the levels of theophylline into toxic levels. So no Cipro. And that's pretty much all I just said. Arrhythmias, probably our biggest concern with theophylline side effect wise. Patients also, headache and nausea are two of the biggest early signs of toxicity. So patients that are on theophylline, if they become toxic, they'll start to get real nauseated, they'll vomit, they'll have a really bad headache. So that can be like an early predictor of this patient's probably their theophylline level's too high. We good? We got like a couple more slides and then we'll take a break and come back, okay? When we get through this part, we're pretty much almost done because it's pretty easy from this point forward. Okay? You can combine bronchodilators, so it's totally okay to have like tiotropium and salmeterol or albuterol and ipratropium. It's totally okay to combine those mechanisms, and if you combine them together, they're additive effects. So it's kind of like adding one's effect on top of the other. So it's really common in COPD because, like I said before, it's additive. And as you go on, patients are going to have more and more medication needs as their lung function worsens. Inhaled corticosteroids, even though COPD is an inflammatory disorder, it's historically thought of as a steroid-resistant disease. Okay? So typically, patients who have asthma, we give them steroids and they get so much better so quickly. They'll have these huge changes in their lung function. Okay? You give somebody with COPD steroids and you get like minimal changes. Okay? Not quite as much. Another difference here is that the isolid trial is actually what looked at steroids, or one of the trials that looked at steroids. There's also the TORCH trial. And those are all online if you're curious and you want to look at them. I posted them all on D2L, kind of like the landmark trials in COPD. So pretty much these slow the rate of exacerbations, improve your health status, but over time they don't alter the decrease in your lung function, just like every other therapy we've talked about. In COPD, the doses are higher. So like the Advair 150, dose, or the lower doses of like Symbicort or Dulera, those are for asthma patients, okay? When you get into COPD patients, you've got to start with higher dose steroids. So the studies that looked at these drugs looked at the Advair 250 and the Advair 500. They did not look at, and I'm just using that because that's the name brand product that was used. So higher dose steroids is what has been shown to be beneficial in COPD. And the last point there is really important because this has actually become kind of a hot topic, is if you withdraw inhaled steroids from a patient with COPD, you can actually cause more severe and more rapid onset of exacerbations. So just like anything else, if you take a therapy away, you can get a rebound effect, and that's true with inhaled steroids for patients with COPD. Let's see. Okay. Pretty much, like historically, we've thought about steroids in patients with FEV1 of less than 60%. That's where they've shown the most benefit. So patients who have lots of exacerbations and an FEV1 of less than 60%. But I'll just go ahead and tell you now, pretty much now, anybody in C or D is going to get a steroid. They're indicated that that could be a potential treatment for that patient. Okay? So this is not quite as important now, but historically, that's where the evidence shows us that COPD patients benefit the most from steroid therapy. We talked about oral steroids in asthma and how you could sometimes give a short course of oral steroids to patients to kind of bridge the gap between inhaled steroids to get a really quick improvement in their lung function. We used to also do that with COPD patients. So we would give them like a 10-day course of prednisone to see if they responded. And if they responded, we'd say, oh, we should probably give them an inhaled steroid. So that would be like our test, our litmus test to see if that patient would respond to an oral steroid. But in COPD, that doesn't work, and so that's not recommended anymore. Because all you're doing is exposing a patient to a systemic steroid, and it doesn't tell us anything about how steroids inhaled are going to work for that patient. You guys know about all the side effects. Pneumonia, specifically, oh, sorry, I didn't mean to write over that. Okay, pneumonia here. A big one in COPD. So it's been shown that patients who have COPD and they're on inhaled steroids have like I think it's like maybe a 3-fold pneumonia risk. Don't quote me on that. I'll have to look back at it and double check my numbers. But their risk of pneumonia is quite a bit higher if they're on an inhaled steroid versus if they don't have an inhaled steroid and they just have COPD. And all those patients, regardless, if you have COPD, you have an increase for pneumonia at baseline. Okay, you can add long-acting betas and inhaled steroids. That's where the Advairs of the world came from, right? They're actually synergistic, and both medications modulate the function of the other medication's receptor. So you get more bang for your buck if you add those two therapies together. Still does not change mortality, but helps improve symptoms. And the last thing on here is triple therapy. So you'll hear people talk about that patient's on triple therapy, and that just means they're on that combo inhaled steroid long-acting beta plus a long-acting anticholinergic. Okay, that's one of my abbreviations for long-acting anticholinergic. You'll also see that abbreviated as LAMA, long-acting anti-muscarinic agent. Okay, so you'll see, like in the literature, it'll say LAMAs or SOMAs, short-acting muscarinic agents. Okay, not to be confused with SOMAs. I had a pharmacist I worked with. He's probably still working around here somewhere when I was an intern. And there was a patient that he just loved to tell the story. He'd laugh. It was so funny. So this person was on Soma. And how do you say the generic for Soma? Right, Risperdal. this person would call in and say, I need a refill on my crispy deals. Can you refill my crispy deals? And he just thought that was so funny. And it was pretty funny. It was like, I don't know if that's a cereal or a pickle or something in between. So, this is becoming more and more common in COPD practice because it's additive again. So patients over the course of their disease are going to end up on multiple inhalers. PDE4 inhibitors. We'll talk about these quickly because, quite frankly, I think they're crap, but you can form your own opinion about that. This is the most recent therapy we have regarding COPD. It inhibits the PDE4. It's an oral tablet, which is kind of novel, right? Because everything else we talked about has been inhaled. Does anybody dispense this or have seen patients on this? How often are you seeing it? Not very? That's good, because it really is terrible. I shouldn't say that. It's not terrible. It's just not my favorite. Okay? This is what it's been shown to do, basically. Reduces the moderate to severe exacerbations when treated with steroids about 15 to 20%. So it's an exacerbation decreaser. It has anti-inflammatory properties, okay? Basically, the way this guy works is if you have a PDE4, this is where the enzyme works, the PDE enzyme, and it breaks down cyclic AMP. And if you inhibit that, so if you block that, you have an increase in your cyclic AMP levels. And like I said earlier, if you have an increase in cyclic AMP, just like with long-acting beta agonists, you get bronchodilation, right? You also, with PDE4, get a suppression of immune cell response. So patients with COPD, neutrophils and other immune cells will kind of like migrate into their lungs and cause that inflammatory response because that's your immune system, and they're kind of like, they're releasing like cytokines and all these inflammatory mediators, interleukins, all that stuff that you guys remember talking about a while ago. And so if you can stop those, it basically makes them stupid, okay? So PDE4 inhibitors basically make your white blood cells stupid, and they're lost in the dark. They can't find your lungs anymore. It's like, I don't know which way to go. So that's how they think these guys work. Kind of the take-home points I want you to remember about these are the side effects because they're significant, okay? GI disturbances can be so severe that patients literally can't make it through those first couple of weeks of therapy. Think about like metformin. Like if you gave somebody like 2,000 milligrams metformin and they've never had it before, those are the kind of side effects these patients can sometimes have with this medication. Especially, they'll kind of grow out of it over time after they get used to it, but initially it can be pretty significant. Sleep disturbances, really vivid dreams. I had a patient once that told me he liked it because of the dreams he had. And so he was like, I don't really care if it helps my lungs, but I'm having a lot of fun when I go to sleep. I was like, all right. So, yeah. Weight loss. Yeah, I know. It's crazy, right? You never know what you'll hear. This is significant because patients, like I told you earlier, are malnourished with COPD. They're going to lose weight over time. And so you've got to be careful if you have somebody that's already small and they've already lost weight. And they're already at like a really low cachectic weight anyway. Post-marketing studies have showed us, post-marketing. So surveillance after these drugs came to market showed us they actually worsened depression and increased suicidal ideation. So what does that mean? It means I'm thinking about committing suicide, right? So there's actually been a couple of reports of people who have completed suicide attempts and it's been related to starting this medication. So if you have a patient with significant psych history, they probably don't need to be on this at all. Okay. Some of the miscellaneous therapies that we're not going to talk a lot about because they don't really have a role in treating chronic COPD. Antibiotics, there used to be a thought that maybe we could give people azithromycin and like prevent symptoms, but we don't do that anymore because it was too much resistance. Mucolytics, so like Mucinex, not worth it, okay? If they want to buy it, it's probably not going to hurt them, but it's probably not going to help them a whole lot either. So if they can't afford it, don't recommend it. Antitussives like dextromethorphan or other cough, suppressing agents. Cough is a protective mechanism for these patients. They need to be able to cough anything they can up out of their lungs, and so they shouldn't long-term take antitussives because it can actually worsen and cause some exacerbations because they get stuck down there and they can't cough it out. So try not to depress their cough reflex. And then morphine, people at the end of life with COPD, there's some people who will nebulize morphine or actually take morphine orally because what's one of the big side effects of opiates? Decreased respirations, decreases your air hunger, okay? So that can be very soothing for patients who are at the end of COPD when they're already air hungry. It basically tricks your brain into thinking you don't need to breathe, and so it can help them with air hunger, but it's controversial and it's not really recommended, but you'll see it done quite a bit. Okay, any questions right this minute? All right, thanks for hanging in. Why don't you guys take about 5 or 6, 7 minutes? Try to be back at 20 after, and we'll start and go through these next two, okay? Okay. I was just thinking, something I meant to, I don't want to send an email out because I hate emails, but, so you guys have, today's the 10th, and your final in this class is on the 8th, I think Monday, if I'm not mistaken. Is that correct? Yes. So we're roughly 1, 2, 3, 4, we're a month out, essentially, from your final in this class, okay? Then it's over, it's forever and ever, amen. It's just a bad memory, okay? Hopefully it's not all bad. But some students had asked about, like, some review sessions, and I know that some of the exams, because of Dr. Stewart being out with baby and other professors being out, have not had reviews. And so I can't take their exams and review them because that's their material. However, I am willing to set up maybe 1 or 2, maybe 2-hour sessions that are optional. If you guys want to come and we could, review big concepts. Remember, for your final in this class, we're not going to ask you the level of detail questions that you got to ask on the exams. It's big concept things. Like you have to know, that a patient with that's newly diagnosed diabetes gets metformin, unless they have a contraindication. Like those big concept things that you have to take away and it's like you can't function without, okay? So those are the concepts you need to focus on for the final in this course. The men's and women's health module is the last module of the course, clearly. And that will not be on your final. So you'll have the men's and women's health material on an exam. And then I think that's on Thursday or Friday. I can't remember. I'll have to look at my calendar. So what? When's our final? Oh, that's right. I'm sorry. We had a lot of trouble trying to figure out how those came together. So men's and women's health will be on that Monday, and then you will not have that material on the final. So it'll be just cards, endo, renal, and my material that will be on your final. Okay? And like I said, it's big picture stuff. It's normally like maybe 1 question per lecture hour, something like that. So it's not a lot of detailed, in-depth stuff. Any questions? So why don't we do this? How about, I hate to ask this because I know you guys are busy, but maybe if class leadership can get together maybe some dates, and I'll email you some times that I have available, and you guys can maybe set something up, and we'll come together and do a little powwow if you guys, it's totally optional, you don't have to come, but that'll hopefully kind of bridge the gap for some of the things that you haven't had a chance to review. Okay, so we're going to fly through this because it's super easy now that you know how all these drugs work, okay? In your goal guidelines, in Chapter 4, you might want to, just take a look at this table, Table 4.4. Oh, dang it, Will, I'm sorry, I forgot to look at that website on the break. I promise I'll look at it at some point before tomorrow. And then the Chapter 6 with comorbidities, just kind of pay attention to that too, because that's important, like we talked about earlier for patients. So we're going to classify patients, and based on their classification, we're going to recommend therapy for patients with COPD. And it's going to be super easy cheesy once you see how straightforward this is, okay? We talked about all those things you got to counsel on. So here we're back to our assessment tool that we have up on the board, right? Does anyone have any questions about this or how you would use it? All right, think about it. If you do, we can talk about it more, okay? This is essentially what that table 4.4 kind of looks like, okay? But it's here. So essentially, I want you guys, for this class, I don't really necessarily care that you know the second options, the second choices, or the alternatives, like for things I want you to walk away from right now. I think it's important, though, that you can recommend a first-line therapy for any patient with COPD. Okay? So that's the kind of stuff that I want you to be able to recommend for me and tell me if I ask you a question on the exam. This other stuff is just different combinations of the same medicine, okay, that might work for different patients because of different symptoms or different preferences. And sometimes it comes down to it works for them because that's all they can afford. And we have a patient assistance coupon and they end up getting it, okay? So let's talk about each group. And this is, like I said, going to go by really fast, so don't let me go too fast. So we talked about Group A patients. So these are our few symptoms and a lower risk of exacerbations. Okay, so these are our lowest risk or our healthiest patients with COPD. Okay, all these patients need, let's see if I can get a different color. Ah, yes. Okay, all these Group A patients are going to need a short-acting beta agonist or a short-acting muscarinic agent, PRN. Okay? Or they could have both. So that's first-line therapy. Okay? Now, you may have patients who say, I don't want the hassle of carrying around an albuterol inhaler all day long. Okay? In that situation, you might just go ahead and give them a long-acting agent, okay? Maybe they work in a job where they can't carry medications with them all the time, or maybe for whatever reason, you know, a great example of this is like prison workers, okay? Because they can't carry anything in with them all day long because they're, you know, in with the inmates and everything, and so they might only have the morning when they get ready for work might be the only time they have access to medications. And so for those patients, or if they prefer it, you might just go ahead and offer a long-acting beta or a long-acting muscarinic agent, okay? But like I said, all I care about you guys knowing for this part is that this is the recommended therapy, a short-acting bronchodilator as needed. This is just for patients who prefer it or their job or lifestyle requires them to only have a long-acting agent. Questions about A? All right, moving on. Group B patients, okay? These are patients that have more symptoms based on their scores. That's what puts them, that differentiates A from B is their symptoms, okay? But they still have a fairly low risk of exacerbations. So their airflow is not that limited, okay? They're not having exacerbations frequently, so their risk is pretty low, okay? For these patients, we're going to have a superior option to give them a long-acting agent. Okay, that's going to be the preferred option, is a long-acting bronchodilator. And scheduled. Okay. Right? Our long-acting agent should be scheduled. All of them. Even if you use a long-acting agent here, it needs to be scheduled. Okay? Good. Now, you may, for whatever reason, decide to combine bronchodilators. Maybe you have a patient that you put on, let's say you put them on salmeterol, okay? And nothing changes here as far as their risk, but they're still having lots of symptoms. You might then add like Spiriva or tiotropium to that patient and have a dual long-acting bronchodilator, and that's okay. You can do that, okay? All patients, regardless of where they are, should have a short-acting agent on board. So all COPD patients need a short-acting bronchodilator for rescue therapy. Okay? Now, if they were on tiotropium here, what would be your preferred short-acting agent? Albuterol, right? So ipratropium, bad news bears to add on top of tiotropium. If they were on salmeterol, it wouldn't matter. Okay? Or formoterol or any of the other long-acting betas. Oh! I was looking today, too. I forgot to tell you guys, there's actually a new Respimat. You know, we talked about Respimat devices and how cool they are and blah, blah, blah. This is actually a new one the FDA approved, I think in July, like end of July. It's called Striverdi Respimat. And it's Olodaterol. It's a new long-acting beta. Okay, it's not out yet, but it's been approved by the FDA, so you'll probably start seeing something like this soon Why you would use it, I don't know. But it's another option that will be available, okay? And because it's a long-acting beta by itself, it's only approved for COPD. Are we good with these? Yes? Okay. Perfect. Group C patients. Okay, so now we're up here. So these patients are having fewer symptoms, okay, but their risk is increased. So they have more airflow limitation and or they're having more exacerbations, okay? So the primary goal, oh, please take this one home with you. The primary goal is to reduce the risk of exacerbations, okay? So for these patients, this is where steroids are going to come into play. So you're going to have an inhaled corticosteroid, long-acting beta, agonist combo, or a long-acting muscarinic agent. But if their second line is any two combination of the long-acting bronchodilators or inhaled steroids. So technically, the reason we usually say inhaled steroids, long-acting beta is because they come together in one inhaler. That makes it easy. It's one inhaler for two drugs. If you want to give somebody a long-acting antimuscarinic and a steroid, you have to give them two separate inhalers. That'll probably change because we're going to have all these new inhalers come out, but historically that's what's happened. So it's just more convenient if you're going to do a steroid to do it with a long-acting beta. But you can do a long-acting muscarinic like tiotropium plus a steroid as well. The PDE4 inhibitor we talked about earlier, its best indication is for patients who have chronic bronchitis as a large component of their COPD. So a chronic bronchitis patient is somebody who's barrel-chested, they have lots of mucus, okay, lots of that really long expiratory phase when they blow out. That's the patient that benefits most from PDE4 inhibitors, and also it's patients who have lots of exacerbations. So because of that, when you get up in these categories, you can consider using PDE4 inhibitors, but they're never first line. Good? This is easy because just like Group C patients, the problem for these patients is their risk of exacerbations, okay? They have such a high risk. So the goal here is to always reduce their risk. So just like Group C, you're going to treat Group D patients exactly the same. So they're also going to get inhaled corticosteroid long-acting beta or a long-acting antimuscarinic. Alternative options here. One I would want you to know that's kind of an alternative but yet very important for patients in these categories is triple therapy. So you could do plus a long-acting muscarinic agent. And that's true here too. Oops, I'm a little dyslexic today, sorry. I have days like that sometimes. Okay? So, if a patient, if you started, let's say you started the Advair, okay, and a patient was still having exacerbations, you're not just going to keep them static because we have more options we can add to that patient. So let's say you started this patient up here on Advair, and 6 months later they come back in the hospital with a hospitalized exacerbation and they've been using their Advair like they're supposed to. They're still at high risk, right? So that might be the patient, and you say, okay, let's go ahead and move to triple therapy and let's add Spiriva. Yes? Okay, perfect. See, this is easy cheesy. So like I said, a lot of students, historically on the exam, what they do is the minute I hand them that sheet, the cheat sheet, if you will, okay, the cheat sheet will have this, not filled in, obviously, but it'll have this, and then it'll also have the equipotent dosing for steroids, okay? So those are things you don't have to commit to memory, but you have to know this stuff, the stuff in the green, you have to be able to put in there. Okay? We talked about this important point. I think I've hammered it in the ground, so hopefully that's clear. Let's see. Like I said earlier, everybody needs access to a short-acting agent for rescue. Okay? So even these patients here who are using those long-acting agents because of preference or because of job, ideally they should still have a short-acting agent at home, okay, to use on top of that if they need it. Theophylline, like I said before, we're not using it a whole lot anymore. It's almost died out. But one place where you might see this is when people can't afford inhaled therapy, because theophylline's dirt cheap. Okay, it's the monitoring that makes theophylline expensive and the side effects. But if you have somebody and that's very rare, honestly. Even with people who are at the lowest socioeconomic status in this country can still usually get access to inhalers. This is usually, like I said, patients who are in underdeveloped countries or places that are not as privileged as the United States. Yes?
So for classifications of C and D,
Mm-hmm.
the therapies don't appear to be different.
That's correct.
So the only
Exactly.
time that it's really important is just that the differentiating the two is when classifying.
Yes, exactly. So if you can classify a patient as C or D, you just have to know one therapy option because it's going to be the same. It's just a matter of, is it symptoms that's making a difference? Because that's the only difference for those patients is how many symptoms are they reporting or experiencing. Okay? But it's still something that is important enough to know about a patient. Are they having lots of symptoms or are they not? But the risk is still the same. Does that help?
Yes.
Perfect. Monitoring stuff. Yes, I'm sorry.
If they're already on first choice, when they progress to D, then you would do a second line additive therapy.
Yes, usually that's what we'll do. Yeah, exactly. So if they come in and they're C for whatever reason, maybe they're C because of, let's say, their symptoms, and they start having more symptoms, and they move over here, then typically we will increase therapy at that point because this is a symptom-driven disease. Okay, depending on what the patient tells you and what kind of symptoms they're having, the only answer we have is, well, here's another inhaler. Try this and see if it works. I mean, it's really kind of like shooting at fish in a barrel. We have no idea what we're doing, okay? I don't mean that like we don't know what we're doing, but we just don't have a lot of therapy that modifies a long-term decline in these patients. We just try to treat their symptoms and slow the progression. Does that help? Okay. Things that you need to monitor in these patients often, spirometry is going to be done yearly. Hopefully, that's ideal to see how their lung function is declining. The average person that has healthy lungs, like us, okay, so typically you peak somewhere in your early 20s with your lung function, and then it's all downhill from there. Sorry, guys, but you're peaking right now. It's all going down. Everything's going to get worse from here, I promise. I'm kidding. So usually a healthy person loses about 40 mLs per year of volume they can blow out, okay, of their FEV1. About 40, 60, somewhere in that neighborhood. A patient with COPD loses somewhere close to either 100 or 120 mLs a year. So you can quickly see how much faster they're losing. So it might take, somebody with COPD might lose, 200 mLs in a year, and I only lose 40. And so you can only get to 0, right? And after that, it's like, see you later. So, let's see, all these things, you can see all that. Just good patient history is really important. This is kind of an interesting one that you guys may or may not see. Polycythemia. So a CBC, actually. So as patients become less able to oxygenate, the body's response is, well, maybe I should make more red blood cells. Maybe that's the problem. Maybe it's me, kind of like blaming yourself. So the marrow will start producing red blood cells like at an inappropriate rate. And so a normal hemoglobin is like 14 to 16. Some of these patients may have hemoglobins upward of 20, okay? And that, you think, oh, that's great, they have all this carrying capacity. No, because the blood gets really thick, and those cells, that thick, sludgy blood, will get stuck in capillaries. So you can have increases in MIs, increases in renal damage. Anywhere there's a small capillary bed, that can be a bad thing. So lots of times these patients will actually do phlebotomies on them. So they'll come in like every week or 2 weeks, and we'll draw blood off just so they don't have that much blood. And that's how we fix it. We don't really fix it. We just keep it from being so bad. So a couple of points I want to make sure that you know about some of the comorbidities. This is another one of those. If I don't teach you anything, please learn this. Cardiovascular diseases, do not withhold beta blockers in COPD. Okay? People have always, that's historically been we can't give that person a beta blocker even though they have an indication for it because they have COPD. Because you're trying to block, or you're blocking the beta receptors here, right? But then we're trying to actually agonize the beta receptors with medication. So we're thinking bronchoconstriction, all those things. But there's actually a lot of studies out now that prove that patients with COPD, they're at increased risk of cardiovascular events because their sympathetic nervous system is always on overdrive because they're always trying so hard to breathe. And beta blockers actually have, in one study, shown mortality benefit in patients with COPD. So that's really cool. So don't withhold those. We try to use the beta-1 selective agents when we can, so like metoprolol, the selective ones. But even non-selective agents are better than nothing, as long as the patient's not having lots of respiratory symptoms related to that. So if you started carvedilol in a patient that had COPD and they had no change in lung function, they're A-okay, keep on going, okay? If you started that and a patient started having exacerbations, switch to metoprolol, okay? Or if you have a patient that already has a lot of symptoms and they're very labile, you know, little things like a virus or a change in weather can alter the course of their disease really easily, start a selective agent first, okay? Let's see, osteoporosis, just over time because of their process, and also because lots of times over the course of life, these patients are going to get lots of doses of steroids, oral steroids, to treat exacerbations. So just, you know, everything else you do for osteoporosis, which you guys will learn about next module when you talk about that. Anxiety and depression, we talked about. Make sure whatever you do that treat this. These patients deserve to be treated for their anxiety and depression, okay? And then diabetes, again, because of all the steroid exposure over the course of their life, these patients are increased risk for developing hyperglycemia and diabetes-like complications. And so make sure that you treat those patients as you would normally treat somebody with diabetes. Just remember here, don't aim for a really low BMI because these patients are going to lose weight over the course of their life anyway. And like weight loss in elderly people is an independent risk factor for mortality. So people who like unintentionally start losing weight, which happens a lot of times in our elderly population, that alone increases their risk of dying over just being old. Any questions about how we treat COPD, just everyday run-of-the-mill? So that's our chronic management. Oh, come on. Let's see if we can make this work one more time. This one's going to be so fast, it's going to it's pretty easy. Okay, so exacerbations, all right? In your book, which now I guess with the online pharmacy it may not, or the online textbook, I don't know if it's listed the same way or not. But there are a couple of tables in the Piro that are worth looking at if you want to look at like the bug causes of COPD exacerbations or, you know, treatment regimens and things like that. We talked about what an exacerbation was. It's just some day-to-day variation in your symptoms. Why do we care? We talked about all this already. So patients never get back to that pre-exacerbation baseline. A lot of times, too, they'll have like a latent recovery period, so it takes a really long time for them to even get back to a normal function for that patient. And while they're in that slow upswing, they're at increased risk of exacerbation. So this happens historically. A patient with a COPD exacerbation will come into the hospital, and we'll see that patient again 4 times in that season because they'll just continue to have exacerbations on top of exacerbations. Okay, because they never really get better. The inflammation's still there, okay? And they're really costly. I mean, if you get admitted to the hospital, you know, you're looking at a couple of grand easily per day. So, this is just about kind of things that might tell us where to treat a patient. I don't necessarily care that you know that stuff, but you should know if a patient walked into your pharmacy and they were distressed, you need to be able to figure out where to triage that patient. So if a patient walked into you and they were, you know, coughing and they were using their albuterol like every 3 hours and they were still, you know, really pulling for air, and they had like skin color changes, they were sweaty. Lots of patients will become like diaphoretic when they get stressed out like that. That's a patient that you don't need to say, go home and call your doctor tomorrow. That's a patient that needs to go get help immediately, right? Versus another patient who walks in and says, yeah, I'm a little stuffy, I don't really know what to do about it, that's a patient that should call their doctor tomorrow. Okay? Those are the things you guys really need to know is what things would tell you where to put a patient when you triage them at the pharmacy counter. The things we use to treat COPD exacerbations are almost exactly the same things we use to treat asthma exacerbations. So bronchodilators, steroids, antibiotics, and then supplemental oxygen or ventilation if the patient needs it. Like I said, a lot of times we'll put these patients on BiPAP when they come in because BiPAP helps them breathe off that extra CO2 they accumulate. Because sometimes they'll come in and they'll have a CO2 level, I think the highest one I've ever seen was 110. And like we said earlier, normal is 35 to 45. So those patients are like looped out of their gourd. You know, they're lethargic. You can't wake them up. When they do wake up, they're saying crazy things. Stuff's floating on the wall. I mean, it's very, very sad to see their mental picture when they're like that. Bronchodilators, this should be easy. Like I said, you know, you're going to use your short-acting agents, so short-acting anticholinergics plus short-acting beta agonist via a nebulizer. Typically in COPD patients, they're going to get a nebulizer over like an MDI or some other kind of treatment if they're having an exacerbation that's severe. If they're just in the doctor's office or at like an urgent care clinic, they may just give them the device to use, but in the hospital we always use nebulizers for those patients, okay? Steroids, we love to use oral steroids in these patients. The guidelines recommend 30 to 40 milligrams a day of oral prednisolone or an equivalent. I'm just going to tell you right now, that's bogus. We use huge doses of steroids in the hospital for patients who have COPD exacerbations. Sometimes we might use like 125 milligrams of methylprednisolone every 6 hours. So, you know, you're talking like 500 milligrams of prednisone a day. Huge doses. So, like I said, not commonly followed in practice. And a lot of patients, when they're that severe, that's not enough for them. They're going to need more steroid. So just remember, guideline documents are made for the general population. We here in this area have a hotbed of COPD, and we have really severe COPD patients. So oftentimes it takes more to treat an exacerbation in the South than it does to treat an exacerbation in Seattle, because they don't have the same severity of disease oftentimes that we have here, especially with this. Okay? So how long should you continue steroids? Typically, they'll say, you know, 5 to 7 days is about the optimal time for COPD steroids to continue. Again, you don't have to taper those patients. They say you can do 5 to 7 days of like that dose, that same dose of prednisone, and then just stop it. Okay? I'll tell you, though, that oftentimes patients who are up here that are having lots of exacerbations and they're very labile, you can't just stop steroids in those patients because they'll rebound and they'll come back. So a lot of times in that situation, it's kind of like your clinical spidey sense, and you're like, that looks like a patient that's going to rebound and have an exacerbation, so I'm going to give them a taper, okay? And you'll taper the steroids down over a longer period of time. We have some patients in Kingsport, if they come in with a COPD exacerbation to the hospital, we'll taper their steroids over like 20 to 30 days. So they'll get a long, slow taper, okay? Antibiotics. This controversial thing, it's not as controversial as it used to be, because there was just recently a study that came out that showed that patients, regardless of the etiology of their COPD exacerbation, did better if they got antibiotics. So we pretty much give them to everybody now. But definitely, these are called the 3 cardinal symptoms of an exacerbation. So sputum volume, so more sputum, more purulent sputum, so that means it's starting to get like yucky stuff that makes you want to go, ugh, okay? It's not like clear, it's like kind of junky. And then increase in shortness of breath. Those are the 3 cardinal symptoms of a COPD exacerbation, okay? So anyone that has 2 of those should definitely get antibiotics. Or if they come in and they're mechanically ventilated, no brainer, right? Recommended length of therapy, 5 to 10 days for those antibiotics, okay? So that's something you should know. You should know how long and what the recommended dose for steroids is, even though I told you it's bogus and we never use that dose. I think it's important you know it. And you need to know how long to treat COPD exacerbations, antibiotics. Yes?
If a patient comes in on a long-acting bronchodilator or like a beta 2, can you keep them on it while they're in the hospital?
It's a really good question. So if a patient comes to the hospital and they're already on a long-acting agent, do we keep them on it while they're there? And oftentimes, yes, we will. There's some hospitals will have protocols, like Holston Valley, for example. Their protocol is they only carry ipratropium. So if a patient comes in and they're on tiotropium, they automatically get auto-subbed to ipratropium, and that's the only one we carry. But usually, like if they take, an Advair or something like that, we'll continue that while they're inpatient, but we'll give them those short-acting agents on top of it to help. So it's kind of, yes, we do, but it's kind of also hospital-specific. What to cover, put some of the main bugs that we have in COPD exacerbations there. You should be able to pick those out. They're very similar to pneumonia bugs. Viruses are a huge cause of COPD exacerbations. Pseudomonas, I put a question mark by because as patients have more severe, long-standing COPD, oftentimes they get colonized with Pseudomonas. And so it'll always be in their lungs, and sometimes it'll flare up and cause them to have an exacerbation. What to use? Primarily, you want to look at your antibiogram to figure out what your sensitivity patterns look like in your area. But our go-to is a macrolide usually, okay? You can also use like an augmentin, an aminopenicillin plus or minus clavulanic acid, okay? And then macrolides, like I said, are a go-to. Tetracyclines we use a lot. Sometimes we'll also use cephalosporins, so like a second or third gen ceph. So like Omnicef, okay? We use that oftentimes for those patients for 5 to 10 days, don't forget. Questions? So we've hammered through all the material lecture-wise today. Tomorrow will be very similar to what you guys did with asthma. So I've printed off some. If you want to get them today or if you want to wait for your group to pick up one tomorrow, that's fine. You'll have the first hour to work on these in your groups, and so you should be able to get through it in an hour, but you might want to just glance at it tonight to make sure you kind of know what to come in and look for. It's also posted online, and then we'll get together after the first hour and discuss them just like we did with asthma. Questions? All right, thanks, guys.